Good morning. Welcome to the Department of Medicine Grand Rounds. Today we have Dr. Abel who's going to talk to us about this interesting topic. But before that, a few comments. First of all, on this day back in 1794 was really the first successful cesarean section. So Elizabeth Hogg Bennett was the first woman to deliver a child successfully by cesarean section. Her husband was a doctor from Virginia, Jesse Bennett, and he asked people around to help him, other physicians, and nobody wanted to do this. So he got a couple of hired hands to hold this woman down while he cut her open with no anesthetic, saved the child, and I assume the mother, but I'm not sure. Now, this was the first time that happened This was the first time that happened in 1794 here, but you got to remember that under Roman law and Julius Caesar's time, the law was that you shall cut the woman open, particularly if she was dead or considered to be dying, to save the life of the child. So this was not new. On this day back in 1890, about 100 years later, was the birth of Rolla Harger. Do you guys know Rolla Harger? He was a toxicologist and biochemist in Indiana. They apparently know who Rolla Harger is. American toxicologist and biochemist who invented the drunkometer in 1931. So he basically made the first successful machine that actually can measure blood alcohol. You blew in a little bag, the alcohol converted into acetic acid, and there were some crystals there that change in color. The more concentration of alcohol. Pretty cool. Louis Terman, born this week in 1877, was a psychologist and pioneer who did a lot of work with U.S. military, doing intelligence tests, doing World War I. And he changed the available intelligence tests at that time to include the concept of IQ. Okay, so we all use IQ now, but he introduced the concept as being the ratio of the chronological age to mental age times 100. Everybody here has 250 of IQ, so you don't need the test. I want to finish with William Prout because today is about the GI system. And William Prout was born this week in 1785. He was well known for discoveries in digestion and metabolic enzymes, but he also studied atoms. So he was very into atomic weights. And in fact, he developed the Prout hypothesis that said the atomic weights of all elements were basically the exact multiples of hydrogen, okay? But he also isolated urea, isolated uric acid for the first time. He was the one who described that hydrochloric acid was present in digestive juices. And in 1827, he was the first to classify components of food in the categories of carbohydrates, proteins, and fats. So that's what's a big deal. But he's probably best known not for his work in digestive diseases, but for the word proton, because Ernest Rutherford named the proton in honor of William Prout. And with that, I'll leave you with Dr. Craig McLean, who's going to introduce our speaker of the day.
Thanks, Jesse. Before I introduce Dr. Abel, I actually got an email from the head of the institute where I do my research at the NIH, the alcohol research, and there's a thing out in a bunch of the newspapers about auto intoxication. So you mentioned the drunkometer. So this woman theoretically has fecal flora that produces her own alcohol and makes her chronically drunk. So it's a pleasure to introduce our speaker today, Dr. Tom Abel. Tom got his research training at the Mayo Clinic and did it with Juan Modulata, who actually really described gastroparesis and gastric emptying problems and was really the leader in the field. Tom then went on to develop his own research career and did really outstanding work and has written a lot of the seminal papers in gastroparesis. He was head of GI at the University of Mississippi for a long time, and we were able to recruit him here in 2012 to lead our program here and to show you how important his work is and how well known he is. He has over a year's waiting list to see him. So if you ask who's the most difficult person to get into, any physician in our medical school, it's easily Tom Abell. Moreover, we added a second person, Abby Stalker, that this is a big, big clinical problem. And with Abby working very hard, we still have a year backlog. So Kentucky 1 complains about this, and what we need to do is just add more physicians. So we hope to clone Dr. Abell. So Dr. Abell's here today to talk about nausea, vomiting, and gastroparesis. Tom.
Thank you. Well, thank you very much. I was telling Jason earlier that I was telling him earlier, in one of my many former lives, I was a struggling musician and used to hear a lot of bands, including our own. And the loudest one ever was the Rolling Stones. I don't know when they were loud when you heard them, but I mean, Mick Jagger was just.
Can you guys can you guys hear him okay? Try one more time.
You could hear him 10 miles away. So, all right.
Okay.
So, in honor of Sir Mick Jagger, I'm going to go ahead and talk.
You're going to have to tell the story again because I didn't understand it. So tell me.
Oh, I just said in my days as a struggling musician before I went to medical school, I heard a lot of bands, and the loudest ever was the Rolling Stones. I mean, this is, I can't imagine those guys can even hear at all, but maybe they can. All right, I'm going to talk today about a couple things, gastroparesis and gastroparesis-like syndrome. And there's my disclosures. Most of our funding has been NIH related. The three objectives, first is to talk about gastroparesis, and secondly, to talk about gastroparesis-like syndrome, and then third, which I have a different order here, to talk about chronic nausea and vomiting. So I'll continue on in about 45 minutes, try to go through this quickly. So the talk is organized first to introduce nausea, vomiting, review gastroparesis, the gastroparesis-like syndrome. I'm going to talk about current areas of investigation, all of which are really NIH funded. I'm going to talk a little bit about treatment of gastroparesis, formulate a hypothesis that, again, has been derived for the last 10 years from the NIH consortium, and then talk about the new exploration. My Christmas present was they called for the new protocol, which was put out December 22nd, due March 3rd. So it's a 30-page grant. So the stomach and health and disease, for those of you that read gut, may have seen this interesting article called The Stomach and Health and Disease, and pointed out that the stomach isn't just the second sac for digestion, but really it's an important mediator for physiology, biochemistry, immunology, and microbiology. And the four big topics were gastric motility, which I'll talk about today. Secondly, appetite and obesity that I'll touch on. Third, immunology and gastric microbiome, which I'll touch on a little bit. And then H. pylori and gastric cancer, which I won't talk about. But it's a good review article if you're interested in. Nausea, vomiting is part of the human experience. It's usually infectious. Almost everybody's experienced it, and it's usually acute. When it becomes chronic, however, it's a problem. It can interfere with nutrition, interfere with function, and thus quality of life. So first I'm going to review gastroparesis. In the three talks that I've given, including here, 3 grand rounds, in 2012 I talked about gastroparesis. 2014 I talked about lateral stimulation, and now today I'm going to talk about gastroparesis and the gastroparesis-like syndrome. The classic definition is delayed gastric emptying, and that's a little bit difficult because it depends how you're measuring it. Usually it's with a solid meal, and there are associated symptoms, nausea, vomiting, abdominal pain being the big three, but also dyspepsia, bloating, and distension, which creates a big ongoing discussion, sort of an east-west discussion between what's severe dyspepsia, what's gastroparesis, and I think it's it's a chicken, egg, and omelet sort of discussion. The classic model would be diabetes, which is well recognized as part of diabetic neuropathy, diabetic autonomic neuropathy. And some patients have delayed emptying, but it's been known for years that some people actually have rapid emptying, a kind of dumping-like syndrome. And others have normal solid emptying using technesium solid label meal, which is the standard meal. Published guidelines were 3 years ago, January 2013, in the American College of Gastroenterology, and I'm one of the authors of those. And basically, we used the grade system to look at evidence-based data, reviewed diagnosis, pathophysiology, diet, drugs, devices, surgery, alternative medicine. And it's supposed to be the guidelines for all practicing gastroenterologists in the United States. It's I think, a reasonably good guideline. I'd like to talk for a minute about nutrition because that's one of the important functions. The stomach really is the purveyor and the beginning of nutrition, even though the pancreas is there to help digest food. Many of our patients are overweight, which wasn't true 25, 30 years ago when I started out. Many of our patients were cachectic. But there are a lot of reasons for that. If you look at the published data from our consortium, food frequency questionnaires, 80% of the diet is carbohydrate, which I think is a part of the explanation for why many of the patients are obese or overweight. We did a detailed assessment of nutritional deficiencies that we published in one of the European journals. And the most consistent was actually vitamin D deficiency, which corresponds with gastric emptying. The more deficient vitamin D, the slower you're emptying. And as we've seen in many other things, recently vitamin D is very crucial. There were some mild B vitamin abnormalities, but there really were no micronutrient abnormalities. That's been looked at a number of times. The NIH Gastroparesis Consortium was actually started by one of my patients, who is the mother of 2 children that had got a post-viral-like syndrome. Mother was Canadian, was an American citizen living in Canada, and she basically started this concept on her kitchen table by writing every congressman and senator over and over again, and that led to the NIH getting involved. I was one of the original senators. The University of Mississippi moved here for phase 2 at UofL. And Mississippi, we were the only center actually in the top 3 for recruitment. We continue to do well here, and we're up for renewal again. It's an open renewal, so we'll see how it goes. But there are a number of things from the consortium. It's been a registry, so it's the most robust database now, 700 or 800 patients, each filling out 70 to 80 pages of data, physiologic testing, followed every 3 to 4 months. We've also had a pathophysiology study publishing a number of items, articles on the anatomy of gastroparesis, which I'll allude to. We also have a couple articles I'll go in more detail on electrophysiology. We published a couple of drug studies, one on nortriptyline and JAMA about a little over a year ago. And that was, I'll talk about that. Another one, Apron, is pending, a Prepitant or Amend. We have another study just submitted to Annals this week on glucose control using current technology for controlling glucose to see if it prevents, basically a safety study, but to see if it prevents progression. And then we have ancillary studies, 2 of which I'll talk about today. So I'm going to talk about Gastroparesis-Like syndrome. We originally enrolled in the consortium a maximum of 25% of people that were not delayed emptying to see what they were like versus the delayed emptying patients. And I published in 2011 the fact that if you put those patients side by side, they're identical in every way, I mean, down to the decimal point identical in every parameter except gastric emptying. And we call that the Gastroparesis-Like syndrome. And that's the reference there, July, Clinical Gastroenterology, the usual gang for authors. Electrophysiology has been my interest for 35 years, and it's been known to be abnormal in gastroparesis and nausea, vomiting. Just like in the heart, also, and as you may or may not know, in the uterus, the cause for premature labor is uterine dysrhythmias. So the development of high-resolution technology has changed esophageal motility. If you've seen esophageal motility recently, allowing us to identify subtypes of achalasia, for example, but can now be applied to electrical recordings elsewhere, including the stomach. And I'd like to show you a few of those. This is our article published 2013. These were about 25 patients of mine in Mississippi using an international consortium. So most of the, all the work was done in Mississippi for recording, but all the analysis was done in New Zealand. And basically, this uses an array with 256 electrodes on the stomach of an laparotomy. And then you can look, this is electrograms here, much like cardiograms. This is arbitrarily defined as red as the beginning, blue, purple the end here. You can measure velocity. You can do various contour plots. And what you see with nausea vomiting is just like in the heart. You get conduction abnormalities, you get velocity abnormalities, you get reentrant phenomena. Remember, this should start up down here and go down. You get reentrant, you get blocks. It's identical, and that has been really a game changer in understanding pathophysiology of nausea vomiting. This was looking at the interstitial cells of Cajal, that Ramon y Cajal, who won the Nobel Prize about 100 years ago, first described under light microscopy, and it wasn't confirmed until the 1960s that he was correct. But Cajal and Golgi won the Nobel Prize together for their work on neuropathies. And this is the spark plugs of the gut. Normal controls about 5 to 6. Gastroparetics with delayed emptying around 2, and that'll become important in a future slide. So what about electrophysiology in people with the gastroparesis-like syndrome that don't have delayed emptying but have nausea vomiting? Well, we looked at that recently to see if those same abnormalities exist, our same cohort of 25 patients, but we looked at the other 12 that had non-delayed emptying. And this was published this year, July 2015, and the usual cast of characters for authors, an international group. And you see the same sort of array. It's a little bit blurry, taken from a PDF, but you see normal conduction here, and then you see the same kind of abnormalities, just like with gastroparesis. You get conduction blocks, you get reentrant phenomena. Very similar. The thing that's probably the most important slide that I'll show you today is this slide. Here's the controls, 5 to 6 per high-powered field for the spark plug wires, the Cajal cells. Here's gastroparesis, about 2. Here's chronic nausea vomiting right in between. So it's pretty clear to us anyway that when you get nausea vomiting, you get damage of the Cajal cells. When they become further damaged, you get delayed emptying. So now, is this just a progression of let's say, fatty liver to cirrhosis? Well, perhaps I'll show you in a minute. Or is this angina that then goes on to an MI? That's still unresolved. But I want to talk about rapid emptying a little more before we talk about anatomy. The original data was 123 normal controls, which is used worldwide. The 95th percentile was 10% retention at 4 hours. So even though it's an emptying, we look at retention. So retention at 4 hours. Actually, the 90th percentile is 6% retention. So if you have somebody that has 6% retention or more 4 hours, they're actually delayed. But there was no data for rapid emptying, so we took the original data, which I had from, it was done in 3 continents, 11 centers, 123 patients, and analyzed it for the rapid emptying, 5th and 10th percentile. And we compared that also with gastric stimulation, something I talked about 2 years ago, an interest of mine, and it's still controversial despite 2 meta-analyses showing it's clearly effective. We looked at basic patients that had temporary stimulation, whether they were delayed emptiers or not. And what you'll see in the next couple slides is the delayed emptying patients accelerate, normal emptying patients slow a little bit, and rapid emptying patients slow more. And this was just published actually with an editorial saying that, that it's a game changer for stimulation. So here's 3 groups: delayed, normal, and rapid, delayed, normal, rapid, delayed, normal, rapid. Here's what happens to their symptoms with temporary stimulation, 5 days on electrode. We do about 300 of these a year currently at Jewish. They're identical. Here's what happens with their emptying, delayed, normal, rapid, delayed, normal, rapid, 1, 2, and 4 hours. And you see the delayed patients accelerate, the normal ones slow a little bit, and the rapid ones actually slow down. So you get normalization of emptying with stimulation. And actually, the group that does the best are the people from another group, 800 and over 800 patients we looked at recently. The group with the normal emptying and normal electrophysiology do the best overall. Those are the people that the insurance company would say we're not going to implant because they're not delayed. But we know now from our data that they probably do have damage. So I'm going to talk about some current areas of investigation. Most of this is NIH funded. Before I do that, I'll talk a little bit about data on mortality for gastroparesis. One of our leaders at the NIH, when this was funded, who's a very great guy, said, well, this is important, but at least nobody dies from gastroparesis. However, we've discovered that that's not true. And here's a study that I did of 97 patients over a 10-year period. 68 were delayed, 13 of whom died, 29 non-delayed, 0 died. Actually, that's a worse mortality than a current mortality for congestive heart failure. And if you look, this is from abstract data, but we're working on the publication. The baseline vomiting of those that died are much higher than those that are delayed, alive, or non-delayed. And their gastric emptyings are worse significantly. And this is a measure of severity of illness measure, much like Medicare uses for DRGs. So clearly you can die from gastroparesis, and we have, sadly, about a patient a month who dies. So the ancillary studies have been a great thing. I'm going to present data from 2 ancillary studies, one which was funded by the Diabetes Consortium, which was an ancillary study here done from September 13 to September 15. We compared patients with diabetes and non-diabetes for autonomic and enteric nerves, basically using old and new technology. And my report in September was 28 pages, just summarizing data, and that was just for the first 3 goals. The next report, which will be in addendum, will probably be another 30 pages, because everything we looked at was positive, despite being a pilot study. So I'm going to talk about that in just a little bit of detail. First, the areas that I'll discuss are markers on autoantibodies. This is an NIH pilot study. Anatomy, this mucosal neuronal density I'll talk about. Physiology, I'll talk about autonomics. Pathophysiology, talk about neurohormones. And then talk a little about energy of stimulation and some autoimmune therapies. So what I'm going to get into now is actually going to be in the 30 pages of the grant that will be submitted. But fortunately, we have a lot of data. So the autoantibodies, autoimmunity and gastroparesis has long been speculated, and those of us that work with diabetes and pancreatic disease realize it's primarily an autoimmune disease. Previous work by myself from over 20 years of data revealed a high incidence of serum autoantibodies and cellular injury. And I'll talk about that. But we used the concept of the antinuclear antibody, which we all measure and which isn't positive very often, and decided to measure it by Western blotting technology, which is a commonly used research technique, much like southern blotting and northern blotting. And this was pilot data from our one site in Jackson, Mississippi. We have baseline 48-week data. I won't go into Western blotting, but there are a lot of ways to look at it. You can look for the presence or the absence of the bands. You can look for the specific bands which have known proteins. These are the things that I learned when I took rheumatology and I took the exam and I forgot about again, but things like Sjogren's, SSA, SSB, RNP. And then you can look for total number of bands, and we have a score that we publish that's kind of like the more bands you have, the more proteins per band, the higher the score. And we've looked at that a number of ways, but we had 62 patients with complete demographic data, and it was the usual female Caucasian predominant, idiopathic predominance, which is what we see in our clinic. And of our patients, over 90% had something. The one that I want to focus about was the RNP, ribobands, and I won't detail on this, but we looked at a lot of areas, but one of them, which is pain, which is the one thing that we don't treat well. And there was a correlation between the worst pain, between the bands, average pain relief, and a work measure related to pain. And those were significant. We previously had published that the one thing that correlated with pain was the presence or absence of these bands. So I think that's part of the puzzle. And I mean, these correlations may play a role. There have been, those of you that follow the GI literature, there have been a number of studies out looking at things like wheat antigens and ANA positivity in things like IBS and other, quote, functional disorders. So this is a hot area and will be pursued more in the future. I'm going to talk next about anatomy. Traditionally, we do full-thickness biopsies, and Dr. Hughes is here today and does about 200 of these for us a year. Unfortunately, it requires a laparotomy, so it's a $50,000 biopsy. And I'm going to talk more about that briefly. We can look at a number of things. We not only look at the Cajal cells by full-thickness biopsy, but we also, in the DICOM study, we looked at mucosal biopsy. It's just a standard endoscopic biopsy, put in a fixative like Zamboni's fixative, done endoscopically, and you can stain for mast cells and you can look for inflammatory mechanisms. So we have a nice lab here, and Dr. Xu Yang and others help us looking at Cajal cells and other cells. If you have a patient and you call me up with nausea, vomiting, and they've ever had a full-thickness biopsy, my next sentence is, please get that sent into the GI neuromuscular lab for staining, because it's very important. Here's from one of our papers. These are Cajal cells, normal controls here, the Cajal cell CD117, and these are unexplained nausea, vomiting with, this is about 6 bipart field, about 4 bipart field. This is another slide from that same article that came out this summer. This is ultrastructural, looking at, here's a Cajal cell, interstitial cell Cajal, normal and impaired in unexplained nausea, vomiting, and it gets further impaired with gastroparesis. The interesting thing that I'm not going to dwell on, but if you look at the fibrosis on electron microscopy, it's present 100% of the time. So these people are developing a cirrhosis-like illness as they lose their Cajal cells. And the thought is that it's inflammatory and it's probably autoimmune in origin. These are mast cell stains. Excuse me, these are mucosal neuronal density. I won't show you the mast cell stains. But this is a normal stomach and a diabetic stomach. This is from the University of Minnesota, where Mike Hughes trained, and he was one of our consultants. This is pilot data that we used for our grant. Here's normal controls. This is reported as length or density, for those of you familiar with how confocal microscopy is done. But here were our post-surgicals, presumably not a lot of intrinsic damage. They had surgery and were not quite the same. They were near normal. Here's our idiopathic patients that were low, and their diabetics that were much lower. And we found the same data looking at that in this new study. Excuse me. So I also talked about autonomic nervous system, which has been another interest of mine. It's going back to my pancreas transplant days. So there are a couple ways to measure the autonomic nervous system. You can do it traditional measures with cardiac things that were worked out at Hopkins 100 years ago. You can also use the postpartum pulse oximetry. If you measure capillary pulse amplitude, it's a very good sympathetic measure that we published recently. So that's a traditional autonomic measure. You can also use heart rate variability. We've traditionally done off Holter monitors, but you can do it very quickly. And we compared both techniques, and they're both equivalent. I want to just point out that we looked at, these were actually p-values for significance. It's a summary of the traditional autonomic measures with electrogastrography and the heart rate variability measures. And this is whether they were diabetic or idiopathic, trying to look for differences. And I had to show this slide because I've never had a slide before where I had significant in every column. At least one thing. This is a baseline temp simulator or change. So there are lots of autonomic abnormalities, which is well known in diabetic gastroparesis, but has not been so well known in idiopathic. The next area I'd like to particularly thank Craig and crew at the CTR building as we've been able to use Luminex to measure neurohormones, and we've done some pilot work before, but never to this degree. We looked at neurohormones using the temporary GES for 5 days as kind of a probe, kind of like a probe in space. We looked at insulin, IL-6, amylin, TNF, and those changed after stimulation. So in 5 days, you get neurohormonal changes. And most of these, I'll show you in a minute, are in the diabetic subgroup, especially TNF, IL-6, glucagon. But also, we found glucagon higher in both subgroups, which is an interest of mine because my work as a fellow, if you give people glucagon, which we use routinely, or used to use routinely in endoscopy, sometimes routinely in ERCP, glucagon actually has receptor on the Cajal cells, and you get dysrhythmias. And you can use small doses of glucagon. And we found both our idiopathic and diabetic patients have high resting glucagons, which is, I don't think, been reported before. We also found ghrelin, insulin, and TNF associated with gastric emptyings, and as I'll show you in a minute, TNF associated with mast cells on biopsy. So here's just a few slides. This is the neurohormonal levels baseline and after stimulation. This is the overall change, insulin, IL-6, glucagon, amylin, TNF, diabetics and non-diabetics, and all the changes in the group really were due to changes in the diabetics. I won't go through the individual numbers, but that was actually exciting for us. This you can't see these because I have a colored slide, but this is a baseline, temporary, and change, TNF, IL-6, and glucagon, and difference between diabetics and non-diabetics. Again, there's differences here in these three, particularly in diabetics. And then this is neurohormonal changes in gastric emptying, primarily for liquid emptying, but ghrelin, insulin, and TNF, more in non-diabetics than diabetics. And as those of you that are familiar with what's going on in the motility world now, there's a ghrelin agonist. There have been several ghrelin agonists, but there's an injectable one that gives rapid improvement in a number of things. A number of neurohormonal conditions that were felt to be untreatable before now can probably be treated with this, including diabetic gastroparesis. That's a trial that we're doing. Here's some information on mast cells and TNF alpha levels from our data here. This is outer muscle and inner muscle layers, but you see the similar patterns between TNF alpha and mast cell count. And people like Pavlov speculated that mast cells were the key to what was going on in the gut. And in IBS, it looks like a lot of what happens with food allergy-related IBS is mast cell-driven. So it may also be true in gastroparesis. There are differences here between the diabetics that tend to have more robust effect than idiopathic patients. But we also found differences between mast cells and autonomic function. So it's possible that a lot of the autonomic abnormalities are due to mast cell infiltration in the gut and systemic abnormalities, which I'll talk more about under therapy. So the treatment of gastroparesis has been difficult, as all our fellows will attest to. I'd like to talk about the biopsychosocial model, which I almost did a fellowship with George Ringel's group. I didn't go to Rochester, New York. I went to Rochester, Minnesota instead. But I was very interested, and I spent 15 years of my life working on this model to show that these were due to personality and other disorders. Unfortunately, I could never show that, so switched back into GI. But I have an ongoing study, still an ongoing IRB study here in Mississippi, looking at follow-up. And basically, the patients have normal ranges of personalities. They're very distressed. They're very upset. And they have some cognitive impairment, as we heard about at Grand Rounds last week, especially in the diabetics. They also have a lot of physical impairment. Our 30-year-old gastroparetics have a functional capacity much like a 70-year-old in a nursing home. We published a major study on tricyclics in gastroparesis. There was 120 patients. 40 of those were mine from Mississippi. It was a negative study published in JAMA December 25th, 2013. There was a number of meta-analysis that just came out in Gut in November looking at psychotropics and dyspepsia gastroparesis and basically found no difference between placebo and drug. So I think the biopsychosocial model is very nice. I spent a lot of my life working on it, but it doesn't explain what's going on with this disorder in terms of pathophysiology. Let's see if I can get my next. I may be stuck right there. I'm stuck in time. So I'll ask for my Jason. I'll ask for Jason. Okay. George Ringel didn't like what I said. He's coming back to haunt us. Actually, he's a great guy.
I don't want to do that.
Next slide.
Let's just do next slide.
Hey.
But it should work. Yeah, there we go.
Okay, great. Thanks. Thank you. Thank you. So recent work from our diabetes consortium, which I haven't even submitted this data to the consortium yet, but we looked at energy parameters for stimulation. And basically, as you'll see, not all stimulation is created equal. So what we looked at were diabetics and non-diabetics, charge energy and power and average power, which are standard electrical engineering calculations that I'm very familiar with. And we found the differences again between diabetics and non-diabetics in terms of how they respond. Also, if you look at the cells, the symptoms, baseline, temporary, and change relate a lot to the Cajal cells. These are S100 cells and mast cells as well. So when somebody gets stimulated, it's probably not only a question of the energy, but also what the cells are, which makes sense. If you have a heart and you're stimulated, it makes a difference what the tissue's like. I'd like to talk a little bit about therapy, a couple of new things on therapy. We have from our, this is not NIH, but from our own clinical database, we looked at bovine serum immunoglobulin, and Dr. Dryden's here. And we thought the gastroparesis and IBD might be interesting because they both have autoimmune factors, the autoimmune that I've described with gastroparesis and autoimmune with IBD that's well known. And we tried first bovine serum orally and then IV immunoglobulin in the gastroparesis. So this is the data from IBD showing this is 12 weeks. You see marked difference in diarrhea and some improvement in nausea, which is very encouraging. In our gastroparetic group, which I'm not going to show you, we only had a borderline change in abdominal pain. But I think this makes sense if you view gastroparesis as a systemic disorder, not just an immune disorder at the mucosa. So we also have a trial looking at IVIG, which is adapted from the neurology literature. And the neurologists have used IVIG for a long time, and with good reason. And we have autoimmune testing that we do, and about 10% of our patients, for example, have channelopathies, sodium-potassium channelopathies, and other abnormalities. This is 12 weeks of IVIG on people that failed everything, failed drugs, failed devices. And the results are pretty dramatic here. Vomiting, nausea, anorexia, abdominal pain, total symptom score, and also borderline diarrhea. There was not a change in constipation. We also looked at other pelvic floor symptoms. So I've been trying hard to get this funded for a randomized trial, have failed so far. But it's encouraging that we can treat some people that can't seem to be treated otherwise. I'd like to talk about now for a minute a model of gastroparesis, which will be the basis for our upcoming grant. And as I have seen it over the last 25, 30 years, I think there's first an insult, whether it's autoimmune, inflammation, infection, may actually be genetic. And then an autonomic effect, cardiovascular, GI, from a regulatory. One of the first changes you see with diabetes is temperature regulation. And that's when I was in the United Kingdom, they were saying, yeah, just touch the patient with diabetes. If they're cold, they've got gastroparesis. And I thought, well, okay. But actually, it was borderline significant for us. Then the enteric damage, Cajal cells, other neural, mast cells, electrophysiologic dysrhythmias, neurohormonal, pancreatic, and gastric. And I think the consequences of that would be for the insult, the neuropathy, hypercoagulability, which I didn't talk about, but I think is part of the reason for death in the diabetics. I reviewed all the deaths for one of the trials recently for the FDA, and they were all the diabetics that died were all cardiovascular. I mean, there was stroke, MI, pulmonary embolus, and that's well known. The autonomic effect can be nausea, vomiting, tachycardia, sweating. The enteric is primarily enteric, nausea, vomiting, abdominal pain. Electrophysiology can be nausea, vomiting, dyspepsia. As we saw, you can see that with normal Cajal, with slightly decreased Cajals and non-delayed emptying. And the neurohormonal can probably explain for a lot of things, including the fact that a number of our patients have pancreatic disease. Excuse me. it's been known for years that we see people with gastroparesis and idiopathic pancreatitis, people that have never drunk, have normal triglycerides, and Mike Hughes sees some of these people, and Midwest Gastro sees a lot of these people. And I have another recent abstract showing that with stimulation you can improve pancreatic output, and we published actually 10 years ago that you can normalize pancreatic insufficiency with stimulation. So I think that's going to be our pitch for our grant. I'd like to go through again. The organization of the presentation was nausea, vomiting, gastroparesis. Talked about gastroparesis-like syndrome and how I think whether you have delayed emptying or not, you have similar pathophysiologic mechanisms going on, and have this integrated model. Hopefully the take-home, before the take-home, I talk about new areas of explanation. My Christmas present was the 10 to 15-page RFA saying all the things they wanted. Here's a few of them they want. Genetic studies, anatomic functional studies, diabetic, idiopathic, dyspepsia, biomarkers, pain, nutrition, inflammation, obesity, and microenvironment. That was just the first page. And we actually have pilot data on all these, so we hope to address. So again, there's the presentation, and what I'd like to have you take home is that chronic nausea, vomiting can be due to a lot of things, but it can be either gastroparesis or gastroparesis-like syndrome. I actually think whether emptying is delayed or not is probably not very important, except for to know what degree of injury they've had. It makes more sense to me to treat somebody before they get sicker than not. And recently we've convinced some insurance companies, because our patients can average over $250,000 a year in healthcare costs. We've convinced some of them that maybe it's better to treat them even though their emptying is not delayed and get them out of the hospital than not. So in summary, many patients have symptoms of gastroparesis. They may have delayed emptying, they may have non-delayed or rapid. There are a number of recent work, including NIH work, autoimmune, anatomic, autonomic, electrophysiologic, neurohormonal abnormalities are there. Hopefully, as we understand those better, we can understand ways to treat them better. So understanding the pathophysiology is crucial to developing effective therapies. We need new drugs. We have basically one drug, Reglan, that's not a safe long-term drug. That's the only drug approved. We need new ways to deliver devices. We have a way to do our device wirelessly, but I don't have the $1 million to make it for humans. It works well on pigs. New way to develop quality of life. Current PROs don't really show what the patients are telling us, so we need some patient-derived PROs. And new ways to assess and improve nutrition are needed because we still don't understand why 83% of their diet is carbohydrate. I think it's clear it's not the diet alone that causes it, but why are they eating? Is because they can't tolerate fats, can't tolerate protein, which is what they tell us. But why is that? So I want to thank investigators, particularly for DIACOM, many of whom are in the audience here. We had several of from Minnesota, but Shu Yang is here, Mike Hughes is here, Abby Stocker is here, Karen Beatty was our coordinator, Kim Faulkner provided the neurohormonal analysis. We have lots of residents and fellows. I ran out of space listing them all. As they will tell you, if they enter our clinic, I try to recruit them into a study, not as a participant, but as an author. And I probably forgot to list some here. But it's a lot of people. I'd like to thank the clinical staff at our clinic, the research unit, the division, and particularly the department for the residents and fellows that have been invaluable. If you have questions on our methods, I have a methods site, researchranch.net, that has great detail. You can email me. If you have clinic patients that can't even get in to see us, because we do a kind of every week we go through the 20 referrals, of which we can only see about 10 that week. And we have much like a transplant system, we have a scoring system, the sicker the quicker. But if they're having trouble, they can email us. We'll answer them back. You can call me or text me anytime. I'll respond. And I got time for questions. Thank you.
Thank you, Tom. I'm glad that we have like 10, 15 minutes because I have 27 questions.
Okay, good.
I'm only going to ask two to allow the audience impressed about the mortality. I was impressed about the fibrosis, the peripheral neurohormonal levels, the autoimmunity, and then all of that suggests, which was your point at the end, that this is a systemic illness that happens to show up to you because the manifestations were mainly GI, but it's really a systemic illness. How many of your patients have a known systemic problem such as diabetes? How many are otherwise known?
A third.
About a third
Diabetics.
do not have a disease
No,
that you can describe.
a third of diabetics are known.
So the majority don't have a condition that you describe that.
Right.
Okay, so the second question I was going to ask you is, when we have unknowns, we blast them with steroids. Have you tried immunosuppression?
Well, I talked a little bit about IVIG.
I understand IVIG, but I wonder
the
classic low-cost prednisone.
There have been no clinical trials. The Italians have done a number of case reports looking at, and they're anecdotal reports, but there have not been any trials. We've suggested for the NIH curcumin, for example, we've suggested that. That has not happened, but that would be the logical.
Okay. The final question I'm going to have is, since this seems to be a systemic illness, should this be approached, and maybe you're doing that now, it escaped me from the presentation, address this in a multidisciplinary manner?
Oh, it should be.
Should all these patients have a stress test? Should all these, you understand what I'm saying? So that there's a concerted effort to ensure not only while you address the emptying, that there are other issues that might enhance survival and symptomatology and so forth. Yeah,
I mean, my background was 12 years as a pancreas transplant doc, so we got people in and they were seen by everybody, and we had the NIH grant for that, and it was all covered. And sure, I'd love to address it multidisciplinary.
Got it. Questions? Let's start here.
Looking at some of your mappings of the stomach, gastroparesis-Like, it looks like one great deal of EP ablation right there. So I'm wondering, in cardiology, they're working on wireless pacemakers. Is any of that technology spilling over into your field? Does your system have a battery and a wire like most stimulators do?
It does. We published our wireless approach. More importantly, for SPARC, stimulating peripheral activity related conditions, we have a SPARC grant going in. I'm a co-investigator on this Friday, looking at a wireless system. We actually just got IRB approval for a little Holter monitor that we'll start using in the spring here. For that's wireless. It can be done wirelessly. So yeah.
I've tried to impress my friend Dr. Steve Carpenter, who's the chairman of internal medicine down in Savannah, Gastroenterology, and Michigan. And I sent him your thing that said he's famous. Thanks for being here.
Oh well. Thanks.
He's famous or he's famous?
Dr. Abel is famous.
That was great, Dr. Abel. Thank you so much for doing that. So I wanted to reiterate the quality of life issue that you talked to the chair. Thank you for all of that. Help us stay with for that moment. So a couple of questions I had was, one was the idiopathic disease. I know some of the patients that I see, at least they started as idiopathic, but now they are in the kidney going into the hospital. So the issue of using steroids early on, I'm not sure how that pans out when you use the songs. And the second thing was the study showed about the insulin, the ghrelin, and all that. GLP-1 has been between these patients. So early on, patients also have the hypoglycemia. Kind of a little complex. I was wondering if that's something you were. And the third question I had was about a rapid gastric disease as opposed to slow gastric.
Sure. So for GLP-1, it really hasn't been looked at very much. The Australians have looked somewhat at that. And you're right. We see people a number of times who look like they're going to be diabetic and then later become diabetic. I mean, as you know, that's well.
Pre-diabetic.
Yeah. So we see those people. What was the question about rapid versus normal?
Rapid, because some of them, we know you can delay gastric insulin, but I also wonder if some of the hypoglycemia, there is a rapid component to early on.
Yeah, There may be. Our NIH study actually, we're looking at emptyings over time, so maybe we'll get some answer to that. Good question.
Thank you so much. I appreciated how you mentioned the patient's diet, because I would tell you that it's visible illness with terrible quality of life for our patients, and we feel very helpless in how to help impact their quality of life. And given that, what I observe sometimes in our patients is that trials experience bowel rest, and sometimes when they're under the care of surgeons, they're during that time, that sometimes that helps to improve quality of life, maybe keep living and sleep better. And I wondered if there had been, I didn't know if anything like that would not only be helpful for the patient and get a break and help them have better sleep and less pain, but it also might help reset things. I don't know, but I wonder what your thoughts were on period of bowel rest and how you
Well, good thought. Of course, there's a huge debate, as Dr. McClave was pointing out, about whether enteral versus parenteral nutrition, and our patients being hypercoagulable have IV access issues. But we have a number of patients that just can't tolerate feedings. We have J tubes in, they just can't tolerate them, and so they end up on bowel rest. It's difficult to know. The ones I see tend to be, quote, end stage, and so nothing seems to help them very much. So I don't have any answers, but good question.
So our division sees many of the patients for you.
Yes.
Diabetes underscore how devastating and expensive because they wind up with glucose abnormalities, they go weak, vomit. Those are very expensive.
Oh, yeah.
I'm always struck when I see them that how many patients seem depressed.
Oh, they are.
You mentioned mind and body connection. And of course, it's hard to sort out the cause and effect of this. But how much of this is somewhat natural? There may be areas in the brain that are more sensitive to gastric sensitive. Some people more than others. So if you've taken a group of diabetics and just done gastric emptying studies to look for correlation between how frequent the abnormalities correlate with symptoms, perhaps it strikes me as the low testosterone symptoms. I know a lot of men with symptoms of low testosterone, a lot of men with low testosterone, and the Venn diagrams don't correlate. It makes you think that there's got to be something else that we're missing. I wonder if we kind of approach it from that. Just take a group of diabetics and then start out with the gastric emptying studies and then superimpose the symptom score on top of that rather than the other way around.
Good point, and a number of people have continued to look at that. That's one of the things the Diabetes Consortium wants to look at, and on their website right now, their grants are every spring. I don't have any great answers. In our consortium, we haven't found a very good correlation. It's been very poor. Anyway, we looked at emptying and symptoms. But I think one way to think about it is, if you think about it as injury, that the emptying delay doesn't happen until the injury is pretty far advanced. Kind of like chronic pancreatitis, you got to lose 90% of the pancreas before you get steatorrhea. So I don't know how we're going to ever sort that out, but perhaps the neurohormonal studies will help us.
So Jesse and I both like remodeling. So you put these stimulators in, leave them in for a while. Does anything ever get better so you can take them out and patients can live without stimulators, or are they there for life?
Occasionally we take them out, and we did publish an article in Journal of GI Surgery 2 or 3 years ago looking at electrical activity, and it tends to normalize over up to 4 years. But they seem to need it, as Mike Hughes will tell you. When it dies, they come in saying something's wrong, and you check the device and it's dead. And that happens a lot. With the new generation, device doesn't last as long because it's higher energy. But there are some people, yeah.
Is there anything known about the cholinergic system? I mean, this is GI for God's sake. It's all about the cholinergic system. But thinking about the psychological consequences, cardiac abnormalities, is there something? Has anybody looked at cholinergic receptors, cholinergic innervation, that sort of thing?
Oh yeah, lot of interest now that vagal stimulation is available, not just for the Spark grant from the NIH, but now you can get in Europe, you can get a device that you wear on your ear that stimulates the auricular branch of the vagus. It's been used for depression and epilepsy in Europe, and there was just a case report out in animals last week saying it improved GI function. So I think vagal stimulation will be a
little bit of bronchospasm won't kill anybody, so that's okay.
Well, we do some repeat biopsies on people that have had stimulators, and we haven't gone back and looked at that, but we can look at that. The problem with doing repeat biopsies is it's so invasive and so expensive. Perhaps on the mucosal side, if we can develop that, that would be a way to see, because the mucosal biopsy is just an endoscopy. So that's our collective hope. Right. Well, that's the question. Is it overly sensitive? If you have 90% of the patients, our correlation between immunofluorescence and Western blot's about 14%. Yeah.
Any other questions or comments? Well, Dr. Abel, thank you very much. I learned from this lecture also from hints that you made that GI was perhaps your fallback position. We're happy that you made that decision. Thank you.